Ladies and gentlemen, welcome and good morning. Let us hope that today we will be spared any technical difficulties. A warm welcome to all of you on the second day of the Evidence Health-based Symposium. The second session, starting today, will be based on evidence with a focus on RCTs and real-world evidence. We will start with discussing artificial intelligence, so solutions which are applied to healthcare. The second session will focus on digitization, so a transformation of the healthcare system heading towards digital healthcare. And the third session will be focused on local governments. The first session will be moderated by our friend Brian Goodman, and I would like to hand over to Brian now, who will host the whole session.
Good morning, ladies and gentlemen, and thank you very much for inviting me to host this session this morning. Hopefully the sound is okay.
Yes, everything is fine.
Great, thanks, Robert. Just to say that this is a very important session, particularly because if we look at global expenditure on medicines, that's rising at about 3 to 6% a year. And most of that is driven by new medicines for complex disease areas, such as new cancer drugs and those for orphan diseases. At the same time, we're seeing ever increasing prices for these new medicines. We see now for orphan diseases that companies are competing to be the world's most expensive medicine, and that's just unaffordable for countries going forward. Alongside that, we see new cancer medicines and new medicines for orphan diseases launch very early in their history with very little clinical data, and it's left up to health authorities to really start to look at their role and value. And we saw a little bit of that yesterday with Marion and the CMOP program. Again, that's difficult to sustain going forward, particularly if companies are asking, as they are, for new drugs for enzyme replacement therapy and Pompe's disease, I think in the Netherlands up to 15 million euros per QALY, and new drugs for cystic fibrosis up to about 3.6 million Canadian dollars per quality adjusted life year. I think that put the company I think at about a net present value of $37 billion. So perhaps not surprisingly, we see companies rushing to develop new drugs for orphan diseases and cancer and forgetting areas such as antibiotics for infectious diseases. So it is very important, therefore, that we really assess the role and value of these medicines to make sure that we use our monies as wisely as possible, because they are limited across Europe, and that has been made worse by the current COVID-19 pandemic. So to help to answer that, I've got some very four good presenters today. This builds on what Marion said yesterday about some of the real-world evidence in Scotland. So we start with Elena, and then we go on to Bjorn, and then Christoph looking at surrogate markers, which is very important, and finally ending looking at orphan diseases. So I'd like to start, if I can, with Elena talking briefly about, if you like, towards evidence-based medicine and HTA. I would like to ask each presenter to have a little bit of time for discussion at the end of their presentation, and then we'll obviously convene at the end. That's because I'm conscious that some people may not be able to be with us the whole of this session. So at more ado, I'd like to pass over to Elena.
Thank you very much, Brian, and good morning, and thank you for the kind invite. First of all, to say that although the context that you've given it, Brian, is to do with expensive medicines or drugs, and to do with qualities, and also medicines and even devices have been the main discussion we've been having in healthcare. Because of COVID, I will try to give a much broader view. It's very difficult to do that in 20 minutes. Of what we're discussing in public health, what we're discussing in the European Public Health Association, what we're discussing in HTA at the moment, for how public health intersects with healthcare and healthcare provision. Because indeed, because of the pandemic, we suddenly saw some different things emerging. Non-communicable and communicable are not so in their boxes, if you like. Collateral damage, the importance of testing, and so on. So I will try to contextualize more and give some broad considerations rather than focus per se on examples of what we're seeing for AI. There's lots of things emerging on how we calculate data, payments, claims, and so on. I would also like to say that I'm here today with maybe I should switch off the camera so you can see my screen, or maybe we can move a little bit because I can't see it very well, but hopefully you can. So I have different hats. Today I'm with the hat of HTA and of the European Public Health Association, where I'm the Vice President for HTA. I would also like to apologize because at 9:30 sharp I have to join a meeting for the European Medicines Agency, but I will step back in for discussion. So starting with a term which I do not know whether you're all familiar with. It's a term of exponential technologies. Now, exponential technologies have a very specific characteristics. So they are very innovative, they represent technological advances, sometimes combined, particularly when we're discussing machinery or tools and so on, and they may represent multiple innovations from multiple sectors coming together. They exhibit certain concrete or distinctive, let us say, characteristics. They are really inaccessible in the sense of price is very high, they're available to few, and then there comes a time in the curve where they become very much available to everyone. And then, of course, this leads to transformation in terms of how things are done, not only from data generation, data collection, but also in terms of workflows, tasks, and so on. This, for healthcare, of course, has certain concrete ramifications, if you like, in the sense of you cannot be discussing high quality data generation or data generation unless you have the infrastructure. So mostly this dialogue about high quality data, about high priced medicines, about utilizing AI and ML in our workflows pertains to the developed countries, very few countries, if you like, globally. Whereas for COVID, we tried to look at solutions and the relevance of this for the whole world. So, as I said, there are different concrete points. I do not know if all of you are familiar, so I would like to say that digitizing and then digitalizing, which is what we've seen over the past few decades, is not quite the same as digitally transforming. So when we discuss real-world evidence and analyzing all this with artificial intelligence, we may be discussing long painstaking story of the electronic medical record, the electronic health record, if we want to be more comprehensive, claims data, and of course, digital capture, real-world data collection and synthesis. And of course, in healthcare, this may very well have to do with pharma data coming from administration of medicines, or maybe lab data, but could also be, when we're discussing combination of data, could be mortality data, could be plain consumer data, could be the much pain discussion of disease registries or more comprehensive registries. And of course, it could also, when we're discussing communities, and this is a very important aspect because the primary care is a neglected, if you like, field for data collection. This also has to do with data collected from community pharmacies, consumption of over-the-counter medicines, and so on. Now, this is a definition of precision medicine. There was a term that was utilized by the European Medicines Agency back in 2018, and that term was combinatorial complexity. And indeed, it had to do with testing, so utilizing diagnostic tools, testing many people to find who will benefit the most, mostly few. And this has a lot to do, of course, with tumor-related stratification biomarkers, for those of you that are familiar with these terms. Very prevalent paradigm emerging in oncology. We all have different genetic makeup, and different mutations lead to different need for drug combinations. And more broadly, and these are just two examples, if we're discussing public health interventions for vaccines, where again, we may have different patient profiles or different citizen or people profiles to monitor the benefit risk. And I think it is an unprecedented time because terms that were really not familiar, not only to the broad public, but also for many people in healthcare, like benefit risk, like authorization, like market access. They have become very prevalent and they're used much. And of course, to deliver a vaccination program, particularly when we're discussing a pandemic, you need to have the right kind of data. You need to ask the right questions. And this, of course, has multiple sides, let's say multiple aspects. The two main ones is who benefits and to what extent. You have seen, probably you have all heard a discussion of the booster, who will benefit from that, who should have it and where. And on the antibodies, who may experience side effects, how we can stave off, how do we monitor all of that. And this kind, at this rate and at this level of expansion, this has to be done, of course, at a level of collecting data from the real world. So starting with trials, hopefully randomized, where we had them, you need to continue moving forward with data collection for this question. So these are just two examples that we have experienced. Now, there are broad definitions that differ. This is the FDA definition of RWE. And of course, it pertains to a medical product's use and potential benefits or risks. And they relate to patients' health status and healthcare delivery. So the two are inextricably linked. Having said that, it's important to keep in mind that these affect different interventions or different designs of studies. So to the question that's been asked now for many, many, many years is, can we substitute RCTs, and should we substitute RCTs with new technologies? But I would argue, and I think many of us in evidence-based medicine would say that these are complementary sources and they answer different questions, and we need all of them. So additionally to observational trials and to incorporating pragmatic elements in assessment, I will speak just for 1 second a little bit more about DCTs, because decentralized trials was a component which was for all of us always of great interest. But with COVID, we saw that to be able to conduct clinical trials, it was critical to move away from the physical location and start discussing more, which was already there, discussion, electronic patient-reported outcomes, conducting trials remotely, extending perhaps the duration or the components of the trial with a virtual participation element, and so on. And of course, there's traditional clinical research and decentralized research, and that extends much further and can allow for different kind of measurement and of data to be collected. Now, talking about data collection, I think for those of us that are in Europe, we have heard for many years the need to have interoperable sources for data exchange, and also operational interoperability and semantic interoperability. But what has not been discussed so much is, for healthcare, is the relevance of potentially GDPR or secondary use of data. So, question that's currently being asked at the European Commission globally is, to what extent do we need to look at AI regulation and legislation in the context of secondary use of data, data processing, data exchange, and is that critical for innovation? So in terms of how does artificial intelligence catalyze healthcare, there are indeed different things that it can do, and to some extent we're starting to see some examples of that. The slides hopefully will be there for you to refer to, but there are some examples in where we're seeing the paradigm shift emerging in terms of data shifts. And yep, let's see, there we go. So these are some of the startups that are really transforming healthcare in different ways and for different kinds of devices. You may also have heard the term of software as a medical device, and I think moving forward, all kinds of drugs, medicines will be monitored. We'll have if you like, a complementary device looking at their effect. And this linked with decentralized trials will allow us to do many things. But we are also discussing more and more in terms of startups, preventive care. And this component of preventive care will become, I think, increasingly combined with genetic data, a very big part of how we provide healthcare, will transform healthcare in the future. Now, important is to look at what do we synthesize and what we look at for our WD. So how do we actually RWD to RWE? We do indeed already look, and we have this happening in different networks at the payment of clinical services and on how we respond to public health crises, like the one we're experiencing still. And of course, looking at other complementary data which could not be necessarily related to healthcare, but could be coming beyond healthcare and could pertain to accessibility and affordability across different regions or different groups of people. And therefore, public health is very important to look at different determinants for people accessing care. Critically, I think it's important to remember that when we discuss real-world data, we're not doing a slice capture in the population. Population needs and trends shift, so you need to have continuous monitoring, is what we call pop, sift, and data drift. And often we see systems or partnerships merging with each other, and we see radical population or changes, also preference changes. And in terms of comorbidities, of course, trials, as you all know, I'm sure, have a very strict inclusion and exclusion criteria. And when we're discussing implementing or utilizing the medicinal products that we have used in a clinical trial setting in real world, we need to monitor their effect. There are some concrete risks and some concrete opportunities in that. So what we have seen that we could be monitoring, for example, payer claims with machine learning tools or basic algorithms, and we can be using AI for that, particularly for diagnostic purposes or for prognostic algorithms. But we have seen already that in some cases we have overestimated the value. These are still early days. And also we have seen that in some cases we have concrete examples where these tools have worsened disparities. And of course, the very different kinds of bias methodologically would take us a few hours to go into, but I have added a few examples of what we've seen to keep in mind. So if you look at examples that are coming to us from oncology and dermatology, the kind of data you feed into a system is the kind of data or the kind of evidence or advice that you get out of the system. So we've already seen examples of this happening. And of course, these are the obvious, if you like, or the first emerging evidence where things can go wrong or where we can consider over-promising. And we have cases where we have seen devices or software as medical devices or even simply digital tools facilitating care provision or interaction, providing advice that we would consider, for example, unethical. And there are other issues emerge there in terms of accountability and in terms of what the intent in utilizing these tools is. Is it simply cost effectiveness or resource allocation, or does it go well beyond that? So we go into intent and causation. We have had examples where things have gone wrong. And of course, we always talk about ethics by design and about very clear intent on what kind of data we're collecting, and the patients and the citizens knowing what kind of data utilization we have. That is not always possible. So in the two examples we saw before, we saw misdiagnosis because wrong kind of data, if you like, than the data we comprehensively had needed for accurate diagnosis entering a system. And of course, there, in the issue of accountability, the question that arises, and I think it will become more and more prevalent, is who is responsible, who is accountable? Is it the machine? Is it the person using the algorithm or the machine learning tool or even the AI tool? Is it the purchaser or the decision maker of utilizing such services at a given time? Is it the regulator, or indeed is it the company or the entity having produced it? And moving one step further from that, we are already seeing changing paradigms with claims assessment coming in and more life cycle monitoring from payer records. We're also using this is a good type of information to look at, to monitor for potential fraud in claims and so on. So we are seeing at the moment a heightening, if you like, of regulatory oversight. And this, if you look at the legislation emerging for AI, it's trying to capture all this. Very quickly, Yeah, that's the definition that we have for health technology assessment, updated from HTAI from last year. So indeed, HTAI...
Alert from calendar, EMOPOG.
Sorry, that's for the AMA meeting coming up. So indeed, we have different opportunities for AI. The opportunity is there, both diagnostically and prognostically. And we do have an opportunity for optimizing our workflows and optimizing our task flows in hospitals and across settings of teams, potentially also for resource allocation. We also have some less explored aspects which have to do with the behavior of people, with compliance, and their decentralized trials can be of amazing benefit. But again, we have to go back to question the information, the communication with the people, the participation in the decision making. And of course, HTA is supposed to very much have different perspectives incorporated into it. So when we're discussing, of course, evidence synthesis, is good also to keep in mind that we have the ability to involve patients more. Okay, going one step further, I think I've talked a little bit about governance. Transferability is another big issue when we transfer a tool across a jurisdiction and it has been developed with different populations. And something that we have been looking at is also how to inform decision-making, the different kinds of things happening. So we have seen already new software as medical devices, so new technologies coming out that are not necessarily medicinal products. So we are starting to look at different things. And these are some examples that we saw in COVID emerging that are potentially of very high cost, but of very high value, but we need to assess that. And there are different questions that we need to ask, and they need to be the right questions to get the right answers. So whether they really help to contain expenditure, but also whether really they improve accessibility and access to care. And this with telecare has been quite an enormous discussion. And there's a new question arising in the global public health perspective in COVID, which has to do with fairness and solidarity to publicly fund the care. So where does resource allocation bring us when we're discussing vaccines, for example, or medicines globally? I think for those of you that are involved more with global health, you'll see that the World Health Organization essential medicines list this year had medicines extremely high, expensive, extremely costly under discussion. And discussing only for developed countries is starting to be a paradigm which is shifting. So moving further, again, COVID has shown that we could potentially have a case of lost opportunity. I think Martin Postma comes after me. He will discuss vaccines a little bit more, what could be done, what is being done, and where we go further. But I will mention 4 examples quickly. So this is what we've done with the European Federation of Medical Informatics, trying to discuss how HCA and discussions of new tools and standards and algorithms, which is pretty basic, should be incorporated in preparedness plan. And this is not open access, but the key messages of the workshop are available for all. And also, being Greek, although I'm in the Netherlands at the moment, we have had the first tool that was utilized to, if you like, manage flows or limit flows for those that will be entering a country and there would be potentially COVID patients and SARS and CoV carriers. So we had the first machine learning algorithm deployed for border control in Greece in the context of COVID, the EBA. Of course, the interpretability of data to know whether this really worked necessitates different population level data, but it was a first effort. Similarly, new technologies which have great impact, but we didn't perceive them as part of healthcare, but we defined the needs in healthcare, are the digital COVID certificates. So, of course, this traditionally is not something that we think in relation to healthcare. So the intersection of public health and healthcare coming more together. And going a little bit further, very, very important to make the decisions on all this on the same basis. This is very important for the population to trust the decision makers and trust the institutions, trust that the allocation is fair, and trust that this is done for their benefit, rather than, if you like, to manipulate them, to restrict them from access, to force them to take a medicine or a vaccine, all of which we have seen, and to some extent we have seen eroded trust in institutions during the COVID period. So for deliberative processes, exponential technologies give us unique opportunities because you have new tools to collect input and to deliberate with people and with patients. So shared decision making takes a new hue. But how we incorporate all of that into a policy pretty much again depends on what a country can do in terms of infrastructure, in terms of data production. So we are at a time where, at least in the European Union, but also in many other countries, we're seeing a need to have specific policies and action plans in AI that are tackling healthcare. We had in the summer the HTA centralized legislation moving forward, but if we look at the pharmaceutical strategy, there's little intersecting between the two. So legislation, regulation are moving much slower than we're moving technologically and where we're moving scientifically. Now, cancer care and AI. Brian started with that. I mean, this needs many other lectures. There has been public hearings, and as you know, there's a focus on cancer by the European Commission. But the potential and what we can really harvest there diagnostically and prognostically has yet to be demonstrated. There are some emerging research showing potential and value for resource allocation, but it's sporadically done, it's not systematically done, and it's not done across wide groups of population, or even, if you like, across Europe, because Europe has started moving towards joint procurement, particularly in the context of COVID. And I think we are also discussing shortages, which is another issue of access, and in which we will see more and more interaction between how we can predict what needs we will have in healthcare. Last but not least, to say that Poland was doing better than some European countries, but not all. Back in 2018, it does have at the moment, since we are with our Polish colleagues, it does have at the moment an AI plan, but much as in many other countries, it does not provide or intersect clearly with HTA or with health and healthcare. It's only focused, if you like, in things like telecare, in things like processing claims data. So the public health potential is not quite realized there. And then last but not least, to wrap up, to say that we have two different hubs. There are many others, of course. So one of the European Public Health Association, and the annual conference is coming up, where we will be discussing vaccines, we will be discussing deliberation, and many other topics, some also having to do with cancer. And we have the hub of RWE and AI at HTAI, and that event is also coming up. What we've done is, because the topics are quite many, I think you've seen me try to navigate at least 7 or 8 topics. We're trying now every meeting that we have, the annual meeting, the workshops, the webinars, we try to upload it freely and to make it available to everyone, not only to members of the society. So I've added in the presentation the links where you can actually access the activities that we have. And this includes a very big 3-hour generation and synthesis of RWE, what we do for HTA once a year. This one is from last year, but we conducted it in June. And this is the upcoming event. So I think you can see the dates there for an imposter. So that has opened. So feel free to convene a workshop or propose a panel, and or to reach out to us, of course, if you are interested in finding out more or being involved with the society and so on. Thank you. Sorry for going very fast, by the way. This is for the interpreters, and this is also for the audience. Hopefully the slides are there with more dense than normal, so you can see the information at your own pace. Thanks.
Thank you very much, Elena. I know you've got to go in 1 minute now for your, is it 9:30? You've got 5. We've got time for...
Yes, of course, please.
One question. Organisers, how do we organise a question? Robert, organisers, how do we organise a question?
Right now.
Okay, so who has a question for Elena before she goes?
I didn't receive any questions from the audience. Brian, please ask your questions.
Okay, well, thanks very much, Elena, for that. One of the great areas or challenges we have in Europe is actually collecting real-world evidence. I know we got Bjorn coming on later on talking about Sweden, and I work in Scotland and work with colleagues in Catalonia. But my impression across most of Europe is actually it's quite difficult to collect real-world evidence, particularly if patients oscillate between hospital and ambulatory care and things like that. So how do you see that progressing in the future so that we can more rapidly look at how new medicines or new technologies are actually working in practice for their effectiveness and safety? And how can AI fit into that?
So this is, of course, the most important question, and you probably heard me say again and again infrastructure because it's on the back of my mind. In a way, we were very successful as Europe or as Western world for COVID. In some ways, very successful because, I mean, come on, you get a therapy within a year or get preventive. It's a success, particularly of partnerships. But not to be able to look back or to look at the data that is emerging, or to be discussing, contextualizing Israel's data versus UK's data, and not have data across Europe with being able to answer the same questions. And I'm discussing the vaccines because everybody is well aware of them. This is applicable to any very costly drug that we have. We should be having this data harmonized. I'm hoping that this will be understood. I understand that we had to invest as European Union or as Europe or as countries, we had to invest in some things, if not all, in 2020. But I think we lost an opportunity to invest in a more robust infrastructure for data collection. On the other hand, I am optimistic because this is not in my slides, but this is happening. I'm involved in it. So there's TDAS. So there is the joint action on the European health data space. And we also have a spin-off from the joint action on health information, FIRI, for COVID-19. And what we're trying to do is pull data in a centralized fashion from across countries. I think it will take a long time to be able to say that we have robust data from hospital, and particularly, and this is very important from to discuss remote areas. We're discussing community level data, so that means primary care is also enabled to collect robust, generate high quality data. And also this also takes some training, because just to add tasks to them without supporting them or without them being able to understand what they participate in is difficult. So it's again a matter of investment. For cancer patients, because this is where I come from and so on, it has to be understood that cancer is a long-term disease, which, however, intersects very much with infectious disease. Think of AMR, hospital infections. Do we factor them in when we're discussing immunocompromised patients? That's just one example. AI or even machine learning, can help there. And it can also inform. That's why I'm particularly interested in how public health intersects with healthcare. So we don't create, for example, picture of what's happening for AMR for cancer patients in Europe in 2021, which is, in a way, not only a disappointment, but, failure of all of us to do that. And the decisions are only as good as our considerations, again. So we need more cross-talking. And it's a touted term, but it's fact. We need cross-sectoral interdisciplinary discussion for these things. It's not yet quite happening. So that's it. I hope I wasn't too long. Sorry for speaking so fast.
No, not at all. In fact, actually, you made a very good point. And with our next speaker, Bjorn, and Magda and others, we actually started collecting and documenting what was happening, what data we can collect on cancer patients across Europe. So we'd like to involve you in that as we move forward, because I think it's, as you said, it's difficult, particularly with patients who cross between ambulatory care and hospital care, as they do with the number of the new cancer medicines. So yes, we'll get you involved in that as we move forward, because I think that
there is the comprehensive care joint action that will be starting next year. That's Tit Albrecht. I think that is pretty much involved with that, and happy to introduce you. He ran the last two joint actions, CanCon and so on. So it's something, I think, which how we tackle cancer in Europe and how this intersects with infectious disease is on the radar, but we need more discussion, and it would be good to see what kind of data we have, what their needs are. And another, since we're mentioning cancer, we never think about it, but the older I get, probably because I get older, I think we don't look much at carers and their needs, and I think the carers of cancer, they consume other types of healthcare and care and other resources. So also we should be looking more comprehensively at who's supporting these patients, which practitioners, and also their families and friends and so on. So for HTA purposes, I mean. So,
Thanks for that. And I'll let you go, and then we'll pick up with you later on then.
Thanks very much.
Thanks.
Bye.
Bye. So thank you again, Elena, for that, and laying the foundation for Bjorn Wettermark, who's our next speaker. I've known Bjorn now for a number of years, and we work closely looking at medicine utilization and its value and things like that. And personally, from experience working in Sweden, they have some of the best data collection, if you like, and real-world data across Europe. So it gives me great pleasure to introduce Bjorn, who can talk about the experiences in Sweden and how that can be used across different countries. So without more ado, over to you, Bjorn.
Thank you, Brian. Good to be here. It would, of course, have been even nicer to come to Poland. I was on the CESTAC meeting in Krakow some years ago speaking about quality indicators, and happy that you invited me to speak about our experience of registries with the COVID-19 as a case. I am professor of pharmacoepidemiology in Uppsala in the university since 1.5 years, but before there I was working in the health system of Stockholm on different positions where we actually worked with collecting the data and doing analysis for the health system. And it's quite nice to have this combination of both being part of the health governance and working in academia. I think that combination is important. We can come back to that. So, COVID, this is the first patient coming to Sweden with COVID. I think all of us remember when the COVID pandemic came the first time. I was with my father at that point in time in Spain. He has a summer house there, and we were sitting and discussing, hearing the news about this ship outside China where a lot of people got infected, and we thought this is nothing related to us, and obviously we were wrong. And not that long later, the first case came to Sweden, and this is a woman in her 20s that came to one of the smaller cities in Sweden. She had been in Wuhan and had carried the infection, and she got isolated here after being treated on a hospital down south in Sweden. And then quite rapidly things happened in all countries, and this is the data on testing of COVID, PCR tests, and the incidence of the disease in Sweden. And it doesn't seem that bad, but as you know, we were quite slow in testing in Sweden, and there was a large number of unknown cases, and this disease has spread quite rapidly. And here comes the intensive care unit admissions in Sweden. As you see, the first cases came here in March and then quite rapidly increased up and leveled off. And then we got a second wave in the autumn also. And here are the mortality figures for Sweden. This is the intensive care is much harder data, of course, than testing, and mortality even harder data. But we also have here challenges in comparing countries and populations, given that some report mortality of COVID, some mortality with COVID, and we have large case mix of population demography, of course, socioeconomics, age and sex in different countries. But obviously, we were quite hardly hit in the beginning in Sweden, but maybe a bit careless. So there were several knowledge gaps when this pandemic hit Europe and the world. We had very little knowledge on the epidemiological measures, the basic ones: incidence of the disease, prevalence, mortality. What about comparisons between different populations in different age groups, for example, and different depending on your risk factors? What about different provinces or regions within a country or different countries? A lot of facts and figures were spread in social media and in different papers, and some universities like Johns Hopkins and WHO did a lot to collect comparable data, but a lot of lack of knowledge here. We knew very little how it was spread. Was it effective with masks? What is effective with other measures or not? We knew very little about the risk factors for being infected and poor prognosis. The first studies were coming from hospital material in China and then came from Italy and other affected countries, but quite little knowledge were there from the beginning. We did not know much about pharmaceuticals. Some seem to be protective, like some cardiovasculars, and some harmful, but very little knowledge overall. No information, of course, about the vaccines. There were no vaccines from the beginning, but they came quite rapidly, that we should be fortunate for all of us. But the effectiveness of safety in real life, also not in the clinical trials, we had no knowledge when they came out on the market. Especially the new vaccines were quite less studied on the elderly, which are the ones suffering most, of course, from COVID. Then we had no knowledge on the impact of the different strategies we took in different countries with lockdowns and other measures to reduce the spreading and the negative consequences and positive consequences. And it's important to emphasize here, it's not only the spreading of the infectious disease and COVID, that is just one part of it. It's the impact of other diseases. You stop doing cancer screening, people did not come to their primary care consultation, perhaps missing a blood pressure that is too high. And also in all disease areas, there are effects of the pandemic outside, beyond the COVID. And it's also the mental health effects with depression and anxiety and other problems, and its economical impact that we still not yet see the final accounts for the pandemic. So there is so much unanswered knowledge here, and many of these questions could actually be addressed with epidemiology using registries, perhaps not all, but quite a lot. And a perfect database to study this and other topics should contain this. We need patient characteristics, we need medical data, we need medications, both those that have been used as prescriptions, but also over the counter. It seems as non-steroidals, for example, had a certain association with COVID. We would need outcome from the patient, perhaps family history, lifestyle, attitudes, socioeconomic data, given that the pandemic seemed to hit quite a lot the deprived areas were in our country. Mobility and travel, of course, how it spread the disease, mortality and causes of death. And this should preferably, when we speak about real-world data here, be linked and standardized with unique identifiers so we can link all data together and we could compare countries and regions. This is, of course, not feasible and possible everywhere, but we can do quite a lot, I think, with the registries we have and many countries tried to build up during the pandemic here. We have the benefit in the Nordic countries of having national health data registries since long. The first one was the cancer registry coming in 1958 with all tumors. Then we have subsequently built up national data registries in the Nordics. It's not only Sweden. I think even Denmark is a little bit ahead of us in having large registries. These registries, it's the same in all the Nordic countries. They are covering the whole populations, so all people in the country. They are supported by law. They are used both to produce health statistics on the number of people having certain disorders and dying and delivering babies, etc. They could also be used for research and epidemiological studies. There is no consent, so all people are included if they live in the country. There is no right to be deleted from the database, but you should be informed about the database, that it exists and what comes out of it. And after a written inquiry, anyone could write a letter to the authorities and get an extract of all the information that is recorded about you. That's according to the Constitution. One very important thing is the unique identifier in this type of data. If we would study certain exposures, risk for COVID, severity, intensive care or mortality, we need perhaps BMI, we need medicines, we need cardiovascular disease, etc. We know there are a number of databases, medical records, registries on different exposures, and there are databases on mortality and other outcomes. But with no unique identifier, we have no opportunity to link it together. So the red thread in epidemiology is the unique identifier of the patient, where you can link different databases together. And here we are fortunate in Sweden and the Nordic countries having a national person identity number assigned to everyone at birth and following you to death. And this is the unique identifier used in all areas of society. It's used in the health sector, in all registries. It's used in the taxation. It's used in the socioeconomic migration, census databases. So basically a lot could be linked for the purpose of research. You need an ethical approval. The data are securely kept in the authorities, only allowable to get access to with an ethical approval and in an anonymized form with encrypted numbers. So these are the national registries we have in Sweden. We have a medical birth registry with all deliveries since the early 1970s. This came after the thalidomide catastrophe, of course. Many countries built up these registries on deliveries and malformations. Here, midwives ask all mothers when they are in the maternal care and the hospitals, what kind of medicines do they use? Do they smoke? Other lifestyle factors? And this is complete with the population since 1974, as far as I remember. We have the cancer registry with all tumors. Unfortunately, not the cancer drugs here, which is something I and Brian discuss a lot, and this is so important, but it was created before we had these new modern cancer medicines available. All diagnoses in hospitals are collected in the patient registry. We have some 100 quality registries built around certain diseases: stroke, hip replacement, diabetes, rheumatoid arthritis, etc., with clinical parameters and in some cases also patient-reported data. Specific disease registries, specifically for contagious diseases. We have the prescribed drug registry with all dispensed prescriptions coming to pharmacists to get them dispensed. The cause of death registry with all deaths and the reason behind the death. Then there is also genetically informative information, population registry, multiple generations, see your relatives, twin registry, and migration. And then you have socioeconomic data also on people, income, country of birth, family situation. And there are also additionally regional registries, of course, like in all countries, I think, on hospitals and in primary care trusts in different provinces. So here, when COVID came, obviously there were a number of questions to be addressed and the registries could be used for this purpose. So we created a Sci-Fi Pearl Consortium. It stands for Swedish COVID-19 Investigation for Future Insights, a population epidemiology approach using registry linkage. And the key, this is a research project, one of the most comprehensive record linkages done so far and far above the others one I have been involved in. And the key person here is Fredrik Nyberg. He is professor of registry research in Gothenburg that took the initiative to join this group of researchers from Gothenburg, from Uppsala, and from Karolinska Institute in Stockholm, covering different disciplines. Then we also invited the key stakeholders, the Public Health Agency, the regulatory agency in Sweden, as an advisory group to our group to see that we do the right research for the need of the population also. And we also have a network of clinicians. If you are going to do analysis and research with registries, I normally say there are only three things you need. You need data, and it's spread out in the health sector, but you need the data. You need the clinical skills. You have to have clinicians, pharmacologists, perhaps pharmacists, depending on the question, that know actually what you're talking about. And then you have to have the methodological skills, how to run the analysis. And these three pieces are not always in the same place. The clinical skills you have in the health system, people working clinically, and the data is spread out in different stakeholders, and the methodological skills you have in the university, teaching about methods in science. You also need money, and we got money from some national research funds. That's also important. It's far less expensive to use registries than clinical trials, but you still need money to set up the database. This is the linkage we have done, and you can find it yourself in the paper. We linked all test results, positive and negative test results from PCR tests. We linked vaccinations. We linked the national registry I told about, cancer, prescriptions, cause of death. We linked primary care from the two largest regions, all diagnoses in primary care. We linked 10 quality registries, intensive care, airway, also COPD and asthma, diabetes, cardiovascular care, the clinical parameters from these registries. And we linked socioeconomic data and census data from Statistics Sweden with the unique identifiers of the patients to a research database. And these are the questions we are addressing in the database. What are characteristics of COVID patients and how do they differ from normal population? Which underlying diseases and treatments increase the patient risk of COVID or unfavorable prognosis as in getting intensive care or dying from COVID? Can we develop predictive models help predict onset and severe prognosis using these massive amounts of data? What aspects of comorbidity, treatment, or medical history increases the risk of long-term consequence of COVID? This is an increasing debate currently in our health system of people having an infection 1 year ago and still not able to work in a normal way. What is the effect and possible side effects of the vaccines in the population, especially for groups not included in the trials, but also the long-term effects? These are some current projects we are doing. It's a large consortium. Some studies being done in different diseases, asthma, COPD, and transplanted, for example. There are studies on medication. This is the project. I'm mainly involved in these projects, given that I'm active in the field of pharmacoepidemiology. What is the risk or beneficial effect of cardiovascular drugs, anti-asthmatics, and psychotropics? COVID-19 risk in people with a foreign background is a special project, given that we know that the pandemic hit the deprived areas quite early. So how is it, what is the risk both to getting the disease, but also the severity? Then we have the vaccinations, effects and side effects here, and we have the long COVID project. The opportunities of using registries like we did here are enormous. I think these exist. It is reduced time and cost for doing it compared to setting up a prospective study. You can get quite large sample sizes. You can get long-term and complete follow-up. You collect your data independently of your research project. This reduces certain type of bias, like recall bias, people remember differently, or surveillance bias, people behave differently if you are being watched. And much information has a high validity. But of course, there are some challenges here also. There may be confounders or important factors that we don't have collected, like lifestyle and attitudes and behavior factors are still difficult to find in registries. Some data may be poor quality, either poor coverage if clinics are not reporting, or poor registration of diagnosis, for example. We know that for certain diseases. There is a limited amount of clinical data still in registries. I think this will change given the presentation we just heard and the explosion of healthcare digitalization in the future. And there is a temptation, of course, to do analysis first and then come up with a question afterwards. And you may find a lot of spurious correlations if you just look into large amounts of data, which are ridiculous and probably false. There could be error in data also. And then this might be an issue. Even in our country, it could take time. And this is my final conclusion a little bit about the project. It's actually possible. We have done this. It's possible to link large amounts of relevant data with unique identifier to get a really nice research database for COVID and also to run analysis in. It's possible to establish a team including different skills. We have clinical skills, methodological skills, a good network with the agencies here. It's possible to conduct interesting and important research. We have already published publications are on the way out. We have had some conference presentations, yet only 2 publications, but more are submitted on the way in now. Then it's possible to attract research funding. There were quite a lot of money from the authorities and the research grant holders quite freely accessible during this period. So it was quite easy to get research funding for this project. But there are some challenges also here. It requires money to set up this infrastructure. But I think the key problem is time also. This is a task on top of anyone else that came from nothing. You have to have an infrastructure for keeping the registries in a safe way. You have to have collaboration skills and patience when you wait for the ethical committee approval, you wait for people's participation coming to meet in a setting. It took some time to set it up, but once there, you can do a lot. Thank you. And you're most happy to respond to some question, or you can mail me, of course, if you have some ideas and questions afterwards also. I have unfortunately not able to be part of the final discussion today, but I can take some question now.
Great, thanks very much, Bjorn. I think because of that, we can just extend the time with Bjorn and then obviously eat a little bit into questions at the end. So does anyone have any questions for Bjorn? Robert, were there any questions?
Can you hear me? There is one question to Björn. If the immigrants are included in these obligatory Swedish registers?
A good question. Yes and no, I would say. The paperless immigrants that don't have got unique identifiers and been part of the system, there are such, are not there. But the majority, those that are second generation, first generation, that got their personal identity number and being part of the system are, of course. And this is a sensitive area, I think, to study, but it's important also to get equity in the healthcare.
I think so. As we got Bjorn, Robert and Christoph on the line, Robert and Christoph, you heard a lot from Bjorn about the project to the end and how they're able to collect and link data from different databases to help them with the COVID situation and some of the key questions that need to be answered. What do you think needs to be done in Poland to be able to move forward like that, given your experiences?
Patients with certain services, we don't get this information from the payer with very short explanation that is not public available information. And if we want to access more complex data, more complicated on different levels to be able to combine this data and to make some real statistics, it will take a very long time, and the results will be far beyond the need when we need this data and we need the results.
So, Christoph, what do you think is the way forward? Because you talked about some of the challenges.
Here, Christoph.
A regulation may be launched in Poland. And this is a very obstructive regulation, which I think should be abolished. Next thing is that we don't require protocols before registry is launched. So you may face a situation where there are two registries which are absolutely not compatible, and data cannot be collectively assessed. So this is waste of efforts and resources. I believe that all serious registries should be based on publicly available protocols, just like clinical trials are. So we need to know who's responsible, what is the way to collect data, who's paying for what, when what is going to happen, and how the results are going to be achieved, and how they are going to be shared with the audience and the persons interested. All these issues should be embraced by protocols. Protocols also allow different registries to be compatible. So we have much larger data if we want to have more precise and better results.
Okay. So how does that fit in? I know you have managed entry agreements in Poland, and some of those will be outcome-based. So how does that fit in with collecting data in those circumstances?
This is very difficult, and pharmaceutical companies are not very willing to enter into managed entry schemes based on outcomes, because let's say more than 10 years ago, these monitoring systems, similar to registries, they were quite efficient. But after some time, unfortunately, they were not updated. So the people hired at the National Health Fund, at the Central Office of National Health Fund, they were, let's say, obliged to pick up some other tasks. And they didn't have time for updates of the registries behind every drug program. So they are still outdated and nobody cares. So legally the data is collected, but this data is absolutely out of any reason, and it's not being used for decision making by any means. Therefore, we need to base them on protocols. They need to be people who are going to update these registers, and then we may think about outcome-based risk-sharing scheme.
I think that's an important point we'll pick up later on. Because Bjorn, I think that the registries you have in Sweden that allows you to better to look at outcome-based agreements if they're taken forward.
No, I think the comments you had are completely, I agree them. You have to have some national authority that can keep a safe environment for this registry. They have to be supported by law. They have to be independent, but there should be protocols also for the clarity and transparency on every, definitely to be able to use this. Even though we have these, it takes time here also. And it's a battle, of course. The media want figures now and the stakeholders, and it takes time to do it in a proper way also. But this is something we have to meet each other, also be a little bit more patient to wait for the true answer, and also be a little bit more rapid for academia and the people sitting on the data.
I think that's very important points. Is there any more questions for Bjorn before he disappears?
There are no other questions from the audience.
Okay. Well, thanks very much then, Bjorn. I think we'll pick up with your good points and what Christoph has just said when we come to some brief discussions at the end when Elena joins us. So thanks very much. I think you've given some very good insights into how well the registries can work in countries and the need to have, if you like, laws and also a unique identifier that covers all sectors. So thanks very much for that.
Thank you.
Okay. Thanks. So I'm glad that Christoph's on the line and we can see him. So I think he made a very good point about obviously collecting data and looking at how drugs work in reality. So I'm very pleased to have him to present on potential surrogate markers in hemato-oncology, because I think this is a key area going forward, because if new cancer drugs are being launched early with limited data, then we need to be able to have some good idea as to their likely effectiveness in practice, particularly if they're allied to a reasonable price figure. So without any more ado, Christoph, over to you.
Bardzo dziękuję, Brian.
Brian, thank you very much. I was asked to speak in Polish. The slides are also going to be presented in Polish, so that's the language of my presentation, but I hope that Brian receives the interpretation as usual. Ladies and gentlemen, hello. I would like to present a certain aspect related to MRD, that is the minimal residual disease, and its meaning as an endpoint in assessing medicinal products in hemato-oncology. But actually, I would like to put it in a broader context. And I will start with reminding you with a recall of a certain division of endpoints into two subsets, or actually two different concepts which include data sets. The first arm is the division into primary and secondary endpoints. When it comes to primary endpoints, we usually have one selected, but sometimes the registration authorities like the EMA or FDA allow for the use of two primary endpoints. Rarely, but even they allow three endpoints. Primary endpoints. The point is that primary and secondary endpoints, the difference between what is a primary and secondary endpoint is important before the starting of the clinical trial. And then it allows us to power the sample. It allows us to calculate the desired size of the sample to allow for obtaining statistically relevant data. And this is specified in the study protocol even before it starts. All the other endpoints which are measured and for which data are collected, data that allow us to draw conclusions, are treated as secondary endpoints. And this division basically doesn't really matter when it comes to market access, when it comes to reimbursement coverage, when it comes to pricing of drugs or medical devices or procedures or any other health services. This division into primary and secondary does not really matter. So which division matters? The division into the hard clinical patient-oriented outcomes and surrogate endpoints. So what's the difference between those main POOs and surrogate endpoints? Well, patient-oriented outcomes, to put it very simply, are outcomes which are significant for the patient and which are the essence of which address the essence of the disease. For example, if someone has a disease and will die, then obviously this is meaningful. So overall survival, which is still very often the primary outcome, which is usually the required endpoint for cancer drugs, this is clearly defined. A person either lives or dies. So it is easy to well define this endpoint, and it is crucial for determining the efficacy of the technology in question. But let's say a fracture of the hip is a very important endpoint for osteoporosis treatments. We either have a fracture or we don't. But the acuity of vision or hearing or pain, all those are endpoints, outcomes which the patient experiences and which should definitely be treated as patient-oriented outcomes, the important outcomes. But otherwise, we have surrogates. These are the outcomes which the patient doesn't really feel. For example, the blood pressure or the level of certain hormone concentrations in the blood. Densitometric bone structure. Basically, this is something patients don't feel. These are surrogate endpoints, but are they meaningless or are they meaningful? Well, in some cases, their meaning is greater. In other cases, not so much. Before I move to the lecture on the slides, I would like to tell you that I am convinced that the OUTMIT's guidelines need to be updated. I'm sure they will need many updates in the future as progress in medicine increases. Whether in the National Health Fund or the Ministry of Health or the HTA agency, employees come and go, new employees come. There is a rotation. The new employees are not necessarily always well trained in EBM and HTA, unfortunately. And those employees, well, sometimes seem to make mistakes by adopting a very orthodox, conservative approach without understanding what really is written in the guidelines of EMA. For example, right now there is an ongoing discussion regarding outcomes. Some say progression-free survival, what kind of endpoint is that supposed to be? It should be disregarded. Only overall survival matters. So this is a very conservative approach because PFS cannot be treated as a surrogate. It is a POO. Progression-free survival is the time from randomization to progression or to death for any reason. So deaths are also included. So the question is, in the case of the question is how is progression actually tested and whether the patient feels the progression. But if the death is included in a PFS measurement, we cannot call this endpoint a surrogate. However, this conservative approach does not allow for treating PFS as a POO. What causes this? Well, in Poland we had a lot of training on EBM. Me and my co-workers also would hold many of those, where we would explain the difference between POOs and surrogates. We would use a specific example of drugs used in heart rate disturbances, where those substances used could increase the arrhythmia incidence. But then additional calculations were performed, and despite the fact that arrhythmia was reduced, the risk of death was increased. And on that basis, marketing authorization was pulled out for this drug. Those drugs are still used, but in different indications than in the 80s. Unfortunately, arrhythmias are something that we cannot simply get rid of, because this results from certain faults in the heart and different parts of the body. But a cancer disease can be eradicated. If we manage to eradicate all cancer cells from the body, the cancer cells are not there, I can consider the patient cured. And I do not need to use overall survival conservatively, but knowing what the meaning and idea of the outcome for the patient is, I can conclude that the disease was removed. So is this a surrogate? No, it is a very important patient-oriented outcome. Obviously, I also want to see research showing that reducing the number of cancer cells has is translated into overall survival. But if I was able to conclude that I have removed all cancer cells from the patient's body, then most definitely it is not a surrogate, it is a patient-oriented outcome. Of course, it is not possible to always claim that I've removed every single cancer cell, but that is a different story. But we have to have common sense applied to the assessment of every clinical situation, every drug. The bottom line is our Polish HTA guidelines when it comes to the meaning of outcomes and endpoints need to be updated. On the slide you can see different types of POOs. So what happens to overall survival when from the starting of administration of the treatment and to death, and that it's at least 10 years of survival. We will come back to this later. Also, other outcomes are used. You can see examples of those. For example, the possibility of performing an HSCT transplant, or avoiding therapies with a high risk of mortality, or therapies with a severe or frequent adverse events, or endpoints related to the quality of life. And very often, quality of life is treated as a clinically important outcome, as a patient-oriented outcome, but how do we measure quality of life? In what time intervals was quality of life measured? So we cannot adopt a solely conservative approach. So we have poor specific scales, which I am not convinced should be used as POOs. So we have to be flexible in our approach. Everything has its justification, and we have to use our knowledge, this ground knowledge, the fundamentals of HTA, for flexible, common sense thinking. Moving on, EMA and FDA guidelines change. So the guidelines everywhere in the world should change as well. You can see an example of the EMA guidelines, regardless of the selection of the primary endpoint. What was also frequently reported was, for example, ORR. The question also is whether our institutions are heading towards a conflict of competences. I analyzed it even before I became Deputy Minister of Health. I put an end to it radically when I was the Minister of Health. But I can see we are now coming back to those a quite dangerous situation where we might be heading towards a conflict with the EMA. So the papers published, the opinions published by the Transparency Council and by the president of HTA, I would say they are in conflict with the EMA. I'm not sure if the Minister of Health really wants to enter this path, this war path. I would say this is absolutely out of the question, because regulatory authorities have the competencies to conclude that the balance of health benefits and health risks is benefit. And on that basis, the new molecules are registered. And if we question the decisions of EMA based on non-updated guidelines and based on non-trained new employees' ideas, then the question is, is the dog wagging the tail, or is the tail wagging the dog? I've already described a few such examples on one of the portals that I run, where the EMA and OutMed are using have a different approach, where OutMed employees do not use common sense. we have been observing a huge leap when it comes to progress in hemato-oncology. The modern cutting-edge technologies have managed to extend the life of patients by 10 or 15 years. Maybe even longer, but we still don't have the data, but the people are still living. So the conservative demand by AOTM to present prolonging of life in clinical trials, is there a point to that? How long should a trial last to get statistically relevant data? Well, that's nonsense. The EMA and FDA have already changed their procedures, their internal procedures. And we have to follow the changing times and also update our HTA procedures. We have to think about adopting different endpoints. And if they are good enough for the EMA and FDA to benefit the risks and benefits, the balance between those two, then I think they should also be good enough for HTA assessment in Poland. And I think that the non-realistic demands made by the AOTMIT officials are nonsensical. I think that it is not easy to find perfect outcomes, but if we can't use overall survival, then we have to think about what we can base our assessment on. One of the main rules of HTA is basing your assessment on the best available evidence. If we don't have what we would want to have, we go one step down. If we don't have that either, we go one step down again. Obviously, we have to keep a certain standard, but in HTA, we can't tell the decision maker that we don't have any data, just flip a coin. No, we have to use the best available evidence and work with that. If we were to delay registration to wait for the patients to die and run the clinical trials for 15 years, and we wouldn't have the relevant data, and we wouldn't have RWE, and we would need to keep the patients waiting for access to a new technology which otherwise would prolong their life, and they would die waiting for the drug. So, minimal residual disease. Obviously, a lot of clinical trials are ongoing for many cancers. They regard the accuracy, the reproductiveness of the measurement and its correlation with overall survival or PFS. And already now for many cancers there are robust and strong and numerous evidence which can be used. And in such cancers, MRD is a strong correlation and a strong prognostic factor in many hemato-oncological indications. The EMA and FDA registration authorities have found MRD as a valuable prognostic factor. And I would like to underline that MRD here, just an example, is just an excuse to start talking about a flexible approach to HTA. The EMA also allowed for conditional registration of new therapies based on the health benefit with regard to MRD. So we need to achieve undetectable MRD. I know in theory we are running out of time, but I know that there's some time left in the session. I will take 3 more minutes. MRD minus is defined as the undetectable MRD, so the presence of less than one cancer cell per 10,000 leukocytes. So a few years ago, those methods were either unavailable or poorly available, and now researchers have at their disposal the various methods you can read on those slides. For example, multicolor flow cytometry, ASO PCR, and many others. Now we can actually detect one cancer cells in one in a million. That's how accurately we can detect MRD. MRD allows for tailoring the treatment to the patient and is the future of personalized medicine, so treating of individual patients. And indeed, MRD is used in personalized care more and more often, a therapy which can actually lead to a cure, not just treatment, but cure in patients with cancer, with blood cancers. Thank you for the attention, and I am giving the floor back to Brian.
Great. Thank you, Christoph, for that. You've raised some very interesting points, particularly around aspects of markers, etc. And I think you're right by looking at MRD in hematological cancers, because we look at surrogate markers for hepatitis C, we look at surrogate markers for HIV. So I think in this situation where there is strong correlation, then I can see this as a good way forward, particularly if patients are living a long time as they do now with HIV, etc. So I think that's something we can come and discussion later on when we come after the next session, because I think that's going to be an important discussion point. So thanks very much, and we'll join you again soon. So it gives me great pleasure, I think, for our last presentation, Margosota and colleagues, to talk about reimbursement, etc., for very rare diseases. Christoph was quite right to say, look, we move from orphan drugs now and ultra-orphan to rare and very rare. So to me, this is a growing challenge, because on the one hand, we do need good therapies coming forward to treat these patients. On the other hand, we've got issues of affordability. And conscious of the Eurodis report just a year or two ago, talking about disparities in availability of medicines for rare and very rare diseases between Western Europe and Central and Eastern Europe, primarily because of some of the prices. So they were arguing for lower prices and increased access. So with that more ado, it gives me great pleasure to introduce Margosota and her colleagues talking about very rare diseases and reimbursement. So over to you now.
Dziękujemy bardzo. Dzień dobry. Witam Państwa serdecznie. Temat naszego wystąpienia: inicjowanie i definiowanie zrównoważonego projektu na przykładzie refundacji terapii chorób rzadkich. To oznacza, że spojrzeliśmy na ten świat z perspektywy zarządczej i spojrzeliśmy też na ten świat z perspektywy podejścia projektowego. I chcielibyśmy pokazać w pewien sposób właśnie definiowanie, zaraz oczywiście powiemy, czym to definiowanie będzie w naszym rozumieniu, definiowania takich przedsięwzięć, definiowania takich projektów, które polegają na refundacji terapii chorób rzadkich, właśnie z perspektywy tak zwanego zrównoważonego rozwoju, pewnego zrównoważonego podejścia. Dlaczego też terapia chorób rzadkich? Myślę, że to w dużym skrócie warto powiedzieć, bo mamy to przekonanie, że ma charakter pewnej soczewki i pokazuje rzeczywiście bardzo wyraźnie pewne zagadnienia, o których będziemy szerzej mówić, pewne wątki, które sądzimy, że warto uwzględniać w procesie definiowania, w procesie w ogóle podejmowania decyzji na temat tego typu terapii. Rzeczywiście jest to
should be included.
inny świat niż te terapie.
This is a completely different world than these therapies we have been talking about until now, and a larger group of patients. So that is just a brief introduction. this is the agenda of our presentation. Just a brief, succinct introduction to what defining projects is, what we think is important, then the specific features of rare disease therapies and the challenges related with that. And then the approach which we believe could be of value, which could point to certain important dimensions for such therapies, sustainable project management and the P5 standard as a certain consequence, a leading standard for sustainable project management. And in our sum up, we want to outline further steps, share our reflection on what the outlook is, what the limitations are that we are dealing with, because every tool, every solution has its limitations. So very briefly, where do we place projects? Defining, where do we see the moment that we can reach for certain solutions which will define more dimensions, more aspects. So defining, initiation is the first step, defining is the second step. And because we deal with project management, then we believe acting in different areas, in various sectors, is important. Many projects fail when at the stage of defining those projects. They come to an end before they are even launched. And we see this very frequently, that many areas lack sufficient attention to the defining stage. We want to move on to the implementation, we want to get results, we want to show everyone that this is working. But we cannot disregard this phase of initiation and defining the project. That's why we wanted to take a closer look at this. So we formulate the framework, we formulate the assumptions, some basic parameters for the project. Of course, the planning stage is yet to come, but at this point we want to outline what we need to achieve what we want to achieve, whose interests we need to take into account, which stakeholders are the most important, who should be included. And we also have to look at emerging issues which were not present at the initial stage of the project. So we have to be on the lookout. A project has to be well thought out. The defining process has to be based on an in-depth reflection. And to sum up this introduction, a well-defined project, also in rare disease therapies, in rare disease treatment, must have a clear goal. The objective must be clearly defined, and it must be formulated in different perspectives. We must define the stakeholders we want to respect in the project. Of course, we have different stakeholders, not just the customers, to use a business term, but all of those interested in the project. If we're only looking at clients, so to say, this will not end well. We need to involve all of those who are not just the direct beneficiaries, but everyone affected, everyone involved. This reduces the risk of failure. Of course, there is an inherent risk in every project, but we can strive to mitigate it, to prevent a disaster in a project. Balancing the roles of project participants. This is where we prevent a situation where any of the roles, any of the participants becomes dominant in the project. So starts to control the project, starts to dominate other participants. So this is a big threat to a project, and this has to be prevented. Feasibility. A well-defined project means that it is a feasible project, that it can be implemented. We have to look at all the interconnected elements and increase the chances of success as highly as possible. So we have to answer three questions. Is our project expedient? Is it feasible and can it be effective? We have to look at these three areas. These are the key questions, and we have to ask them at the stage of defining a project. We also have to ask ourselves how to formulate these questions, and I will touch upon that in a moment. And now I hand over to my colleague. Ladies and gentlemen, thank you, Mateusz, for this introduction. I listened carefully to yesterday's discussions, and we talked about rare diseases. The last decade was about strategic thinking about rare diseases, and it brought a lot of benefits to the patients who had been excluded. We had some legislative solutions to the international level from some very serious actors from the UN, from WHO, from market regulators. We had some cluster structures emerge where NGOs worked together and associated to form larger bodies. There were some alliances formed and are being formed to the end of increasing the chances of rare disease patients. And this looks quite well if compared to the situation from 40 years back, where rare diseases were neglected across the globe. In the year, we can see this timeline of progress in recognizing the importance of rare diseases. And maybe patients would like these to progress faster. But rare diseases is an area rife with challenges, where patients struggle to receive treatment. During today's meeting, we focus on this narrow section. So those patients whom we can help, and we assess that this is about 5% of rare diseases for whom there is a drug. We believe that the awareness of needs in this area, and I'm talking about the awareness of interested parties, not general knowledge. The question is whether everyone wants to understand the challenges, the introduction of new technologies. It's difficult to give some far-reaching statistics in the case of rare diseases. But most orphan drugs are very costly. The sales price is very high. And we could probably devote a whole symposium to the prices of orphan drugs. The problem is that awareness is far from optimal. We are far from meeting needs which could be met. And I think that is the most pressing present problem. This is not just about Poland. WHO is also emphasizing this issue. And this pressure has given rise to new therapeutic options, but these are not reaching the patients. And they are not being distributed in an equitable manner. This is not just. And those drugs, those therapies should be accessible everywhere where we have a treatable patient. And yesterday we had a presentation on Western Pomerania. Krzysztof Wanda also suggested that the funding of rare disease treatment is far too low. When we look at reimbursement of orphan drugs, it is difficult not to agree with that statement. Public funds are limited, of course, and we have a dramatic rise in spending on healthcare. So what we propose, this perspective on orphan drug reimbursement, is much broader and is also related to sustainable development. When we approach this from a model perspective, we would like to include healthcare in the whole socio-economic system. We want to expand this perspective. And we want to look at those reimbursement projects which had not been implemented. In rare diseases, this is especially reasonable, because without support, these are destructive for the patient, for the patient's family. And this destruction expands and engulfs all the stakeholders. Failure to provide treatment triggers a whole chain of interdependencies, of interconnected vessels. While administering a drug at the right stage of the disease helps prevent a lot of negative consequences, especially in the case of rare diseases, patients would get the opportunity from not being excluded for education. They would get the opportunity to become a valued employee, not excluded from the labor market. And if a patient has siblings, then the siblings would not live in the shadow of the disease of their brother or sister. And we also have to look at the broader context, so everything connected with the disease when a drug becomes available. So additional health protection, diagnosis, pharmacological treatments, R&D. Let me just mention some patient organizations. And we all want them to be present because we value their experience and their skills in rare diseases. We had two Madam Professors yesterday, Professor Kotulska among others, who talked about SMA, and that presentation was a joy to listen to. A very specialist and expert presentation. And we also have SMA patients at our institute, so it's very interesting for us. So what we want to suggest to the payer is that the budget is also dependent on what is happening in the budgets of other ministries. To have the payer adopt a broader perspective on these issues. Another issue is that of healthcare migration, because we have drugs present available in some countries but not in others, and this causes patients to migrate in search of available treatment or drugs. Gene therapy, for example, in the case of chronic diseases, it's not a one-off trip. You have to make several trips to receive treatment. And these are very high costs, which could be prevented if these reimbursement decisions were positive in more cases. Now, finding the drug is only half of the job. The rest is about reimbursement. So we have the producer, we have someone who created a drug. We have patients who want to pay for the drug. We have WHO also underlines that we should try to develop reasonable mechanisms for funding and reimbursement. So on the one hand, we need to help those people. On the other hand, these companies, the producers, have a for-profit approach. And this makes negotiations all the more difficult. I would now like to hand over to Joanna so that she can discuss sustainable project management. I would just like to point to where we started defining our project. The previous presentation was very interesting in terms of clinical aspects. Well, we are looking at these project phases. So we're looking at the project consisting not in finding a drug, but in implementing it and making it available. And about these challenges connected with ensuring sustainable project management in this process will be discussed by Joanna. Ladies and gentlemen, thank you very much. A warm welcome from me. Thank you to the previous speakers. Małgorzata presented the environment, the surroundings, discussed the situation, told you what we have analyzed, what we have reflected on, and how to approach the issue of understanding rare disease drug reimbursement. So taking all of these aspects into account, also the social ones, which are quite obvious because we all understand that a rare disease exerts an impact on the family of a patient, on all those surrounding the patient. And so we try to understand the impact of orphan drug implementation in a given country could be on the economy of that state. And to provide a methodological framework, we decided to draw from the P5 standard to define an implementation project. So this matrix, this framework, shows you specific aspects connected with the impact exerted by a specific project on various areas. And this framework can help us define an implementation project because it gives us a broader and more comprehensive view on whether a project should be implemented or should not be implemented. Mateusz also discussed that. So defining a project increases chances of a project's success. And we decided to adopt the P5 standard. Just a brief introduction. This standard was designed by the Green Project team. This is an organization which deals with analysis, implementation, analyzing the impact of projects, not just on financial issues, but also on those connected with sustainable development. In this slide, you can see a simplified version of the P5 standard. How does it differ from what we have been doing until now in project management? Why can it be useful to us now? The P5 approach tells us if you're implementing a project, if you want to implement a project, don't look only at the finances. You also need to look at social aspects, but not only at that. We have certain standards which focus on social and environmental impact. But P5 goes on. Look at the socio-economic impact as well, because you need to analyze the whole environment of the project, impact on the planet, on the environment, impact on the economy of a given country or even the global economy. And we adopted this standard, P5, and we decided to apply it to defining our project. We started with what Małgosia already indicated, so with defining the stakeholders of the project. Mr. Wanda remarked already that this is very important, but the P5 standard, which we use, tells us to base everything on sustainable development goals. And we wanted to show that we cannot limit ourselves to financial, innovative aspects connected to the development of technology. Of course, those are certainly also taken into account, the social reception of a project. But we should also be aware that when we are implementing a project, we can at the same time implement the Global Sustainable Development Policy. And in the first graph, you can see Sustainable Development Goals, which different stakeholders take note of. We have these two basic groups, the decision makers, this is the horizontal axis, and those suffering from diseases and their families. And we can see that they find different goals important. I think it's obvious that patients and families focus on the strictly social issues, exclusion from education, from the labor market, while the decision makers focus on the finances. They focus on potential technology development in a given country. What we want to show is that the proper defining of a project must be based on mutual understanding. In this slide, we showed that the goals, which are not necessarily important for a decision maker, but are significant to the families and the patients, should be analyzed as a whole, as one entirety. We should look at the interests of all the parties. I know I'm running out of time. Still, I want to show you some of the elements my colleague has discussed. What have we decided that should be taken note of, that the reimbursement decision maker should recognize? Which goals should be acknowledged at the stage of deciding whether a given orphan drug should be implemented? As concerns impact on people, then certainly economic growth and decent work should be the goals taken into account, and these should be implemented during the project, because this is about ensuring the possibilities of those people finding work. Migration is another issue. Education for the patient himself or herself and their siblings. This is also about fairness and decent work and economic growth. An element which is frequently disregarded is the drug implementation impact on the economy of a given country. Let us bear in mind that when we are implementing an orphan drug, which has already been discussed by my colleague, we exert impact on the economy. We exert impact on all the services connected with the disease, rehabilitation, quasi-medical services. This impacts taxes, tax revenues. Naturally, this has an economic impact. This is also about decent work and decent earnings for the families of patients. If they have access to the drug, they don't have to migrate in search of therapy. They can stay in the country, work and generate revenue for their families and for their country. So we believe that these goals should form the model framework. Of course, it doesn't take all elements into account, but this model does involve elements which weren't always analyzed previously. I'm being reminded that my time is running out, but I hope that we will get some interesting questions for you and we can continue this during the discussion. What would we like to do in the future? So what we've done until now is applying this P5 standard to the specific situation in orphan drug reimbursement. What we would like to do is prepare a more comprehensive, a more detailed model for defining these projects, which would include the specific features of these projects to a larger extent. What we also want to do is to survey the awareness of stakeholders on reimbursement impact, because now we base our work on the reports which Małgosia said are available. And we want to show that the possibility of applying the P5 standard by drug decision makers and implementation decision makers could serve as a certain stimulator. It could stimulate the introduction of these drugs to our country. And patient organizations being aware of this standard could also serve as a catalyst for their activity. It could give them additional arguments. It could show them that the implementation of orphan drugs, of therapies, of course, very capital intensive, that this exerts impact on the economy, on the environment. These are some extra arguments which patient organizations could use, and we hope they will use them. And then verifying the limitations of the model, so a broad discussion which we want to initiate on this topic. Thank you very much for your time, for the time you took to listen to our presentation, and we are open to questions.
Okay, thank you very much. I'm sorry that the last presentation went on exceedingly long, so we only have a short time for discussion. I think they raised some very interesting points. One thing that didn't come through is opportunity costs. The reason I say that is Eurodis, I say 2 years ago, basically said we want more medicine for rare diseases coming through. We want to increase the number by threefold, but we want to keep expenditure the same. The problem that we have is that rare diseases, or drugs for rare diseases, we now have with new gene therapy that each manufacturer wants to be the most expensive drug in the world. So we have a nuclear option, if you like, to keep driving up prices. We also know it's a very emotive disease area. And I was very conscious this is something that happened in the UK when a Canby was reimbursed. We had 7 pages on a national newspaper. Even Kate and William's wedding never got 7 pages. And that's for a drug that has a cost per quality of $3.6 million. Also, the R&D for that drug was actually paid for by the Patients Association. And the reason the company said they wanted to charge a high price is they knew they could get away with it. And they were recently valued at, say, at $73 billion. So we have this situation where we have a very emotive disease area. Yes, we need new orphan drugs coming through, and Eurodis talked about it, but we also need moderation in expenditure. And I think it's very difficult if we keep saying that we should reimburse every new orphan drug, then that's going to be a fantastic green light to the industry. They just keep upping their prices. So maybe we need to have discussions about opportunity costs, take on board what Eurodis is saying, make sure that companies actually who signed up to it agree with the fact that, yes, we need more drugs coming through. We want to keep the budget the same. And therefore, we do get good equity between Central and Eastern Europe and Western Europe. So I just throw that into the mix because that didn't come through at all in the last presentation. What I also like to say that SDG, that's Sustainable Development Goals, I work very hard with those across Africa because the average patient there gets $1 a day. So they pay $1 a day, and if they're on diabetes, they just can't afford it. So they need new donors coming through for them to be able to afford their medicines. So that's the way the SDGs were developed to help countries such as that, saying how can we make our medicines affordable? How can we manage our treatment for these diseases rather than for higher income countries such as Poland? So I just throw that into the mix. So now I'd like to throw it open for questions. I know we've run out of time, but we got a little bit of a break. So if anyone wants any questions, then please fire them through. Robert, do you want to chair that?
From the audience regarding if any other Polish NGOs has project management, and if you are able to share your knowledge regarding the managing the projects.
Yeah, and also if anyone has any questions for Elena, because she's now joined us.
Chciałabym odnieść się do pytania. Oczywiście nasze polskie NGOsy coraz częściej myślą o tym, aby, znaczy one realizują projekty i coraz częściej również w NGOsach stosują metody, techniki, ta świadomość, jak zarządzać projektem, jak definiować projekty, jest coraz większa. Mamy też opracowania naukowe, tu mam na myśli na przykład panią profesor Marciszewską z Wrocławia, która szeroko opisuje, jak wygląda zarządzanie projektami w NGOsach w Polsce. Także wydaje mi się,
So it seems that we are quite well versed in NGOs when it comes to project management, but the GPM standard and the P5 is a novelty in Poland. It started developing around 2 or 3 years ago, and I think it still is not fully implemented in NGOs, although we know that various enterprises and medical universities have already implemented this standard, and that's the way they analyze their projects. So I think there is still a lot of room for improvement in this regard when it comes to the P5 standard. But the awareness of how to run those projects is already there in NGOs and has been there for several years.
Dziękujemy bardzo. Doszliśmy już do końca naszej sesji.
We have now reached the end of our session. The next session, first of all, I would like to thank all the speakers who gave the presentations and gave it in a very inspiring way. Now I would like to invite everyone to a half-an-hour break. We are starting the next session at 11:30. The next session will be moderated by Magda Włodysiuk and Tania Nowakowicz, straight from Serbia. And this will be a session focusing on digital health. Thank you so much for